I think pros actually is quite not easy, but it has a few basic concepts. If you master those and then sort of extrapolate them, you can work out more difficult cases, you know.
Now, we all know how annoying lower complete dentures can be. I could probably think about 4 dentists in the entire world who like doing complete dentures, and the secret is because they're good at it, right? And one of those dentists that I can think of is Rupert Monkhouse, who's doing some sensational things with his patients, with his photography. It's just absolute art. Now, I've got him because he's so good at removable pros. So today we're talking about exclusively the bane of our existence in removable pros, which is lower complete dentures. In this episode with Rupert, we're going to ask about how to get more predictability, if that's even possible, with lower complete dentures. What are the signs that actually you may be onto a winner and that you may be able to get a suction lower denture, that elusive suction from a lower denture, which you see flaunted on Instagram. I've probably achieved this twice in my career so far, where I've able to get the lower denture suction, and both times you pull the camera out, you record it, because it's such a proud moment, right, to get suction on a lower complete denture. So I'm going to ask Rupert, is there a formula or is it all luck? As well as that, we talk about all the different stages that Rupert utilizes to help him get a really stable lower complete denture. The protrusive dental pearl I have for you is a communication one. It's something that I think as a profession on the whole, we're not very good at, and something that we were never taught. Now, when I learned this technique, I guess it's a technique in communication, it really made a huge difference. And I remember one time in Reading, we were doing an Invisalign open day, and I had 2 other dentists in the room while I was doing a consultation. So we were taking turns, one person was writing the notes, the other person was filling like the radiograph requests, that kind of stuff. So we were working as a team for this Invisalign open day. And I went through my entire spiel, I showed the before and afters, I listened to the patient's wants and needs and how we can help this patient to have a better smile. Now, when it came to the close, i.e., it's going to cost this much and this much time, is this something you want to proceed with, right? So that's called a close, when you close a treatment plan. When it came to a close, there was a silence, i.e., I finished speaking and now there was an awkward silence. Now, what happens, imagine you're going to a patient, you're going to say to the patient, you need an implant and 3 restorations and the cost will be £6,000, okay? And now once you've said that, what happens next? Well, usually there might be a pause for like a couple of seconds before what? What happens usually after that pause? Usually the dentist might say, okay, you can think about it if you want, or the dentist might say, does that not make sense? Because for some reason, that pause is something that we can't fathom. It's something that we can't tolerate. It's something that you kind of panic from that pause, right? So the lesson here, and what I did that day, was that I just let the pause happen, okay? I zipped my mouth shut. I said, it's going to cost this much. It's going to take this much time. Is this something you want to do? I just paused. And it was around about a 20-second pause, right? Can you imagine 3 dentists in the room and the patient, and there was a 20 seconds pause. Now that 20-second pause seemed like probably like 5 minutes. It seemed like an eternity, right? And the patient said, okay, fine, I can do it. And then she's now having Invisalign with one of the dentists at the practice. So the lesson we can learn here is A, respect the pause. He or she who speaks first loses, so don't speak first. Let's give that patient the time. And the way I learned it is that that patient needs that time to just figure out, which day can I come in? How much money do I have? How can I afford this? Is this the right thing for me? In the patient's head, they're probably thinking they're taking about 3 or 5 seconds to respond, but they're in like a trance. They're really just thinking about a few things, and once they've made up their mind, they will then answer. If you rush the patient or if you interrupt the patient, it's so easy to say to them, think about it. And what happens? They go home and they think about it, and the rational brain takes over. Because why? Cosmetic dentistry and Invisalign is an emotional purchase. Okay, and when they say, you know what, I'd rather go on holiday, then that's it. They won't be having the treatment anymore, which is a shame, because who loses out? I think you lose out, but the patient also loses out. Because how many patients do you know who've had cosmetic treatment from you and regretted it? Very few, probably none, because they all, when they have a better smile, are so grateful. And quite often you hear this time and time again. They always say, I wish I'd done this treatment sooner. So that's my elaborate communication protrusive dental pearl for you. Start respecting the pause. Don't panic. Give the patient the time to breathe and the time to think. Hope you enjoyed that one, and I hope you enjoy this session with Rupert Monkhouse. I'll catch you in the outro. Rupert Monkhouse, welcome to the Protrusive podcast. How are you, my friend?
I'm good, my man. Thanks for having me on. Really excited to be on having a chat with you.
Man, I am so stoked to have you on, man. The level of dentistry, level of just removable pros that you do, like it's similar to when I said about Finlay, because I know you listened to Finn's episode, is like the same thing I said to him, I say to you. You are making removable pros sexy. Right? Because sometimes I wonder, and we were just having a chat before we started recording, and I actually thought you limited your practice to removable pros, but then I found out you did extirpation today, you did some fillings and whatnot, and you know, just it's amazing the level that you're doing this at, the way you're documenting. So the first thing I want to know is, for the listeners, tell us a little bit about yourself and how you got into removable pros, and why not composite veneers? Why not facial aesthetics? Why this seemingly specialized route of removable pros, which you've made sexy, which is great?
Yeah, I mean, I graduated in 2017 from King's, and that's really where it sort of came from. Mainly it was my third year tutor when we did removable, started that in third year, and I just had one of those tutors that's just so passionate and such an incredible teacher.
What's the name of the tutor?
Andreas Artopoulos. He's out in Cyprus now. But he was running MaxFax Prosthodontics as well. And I think he still pops over to guys to do that. So yeah, he was my third year tutor and just got me sort of sucked in with it. I went and did my FD up in Hull, and they had the sedation contract for the area. So we'd have once a month loads of patients coming in for sedation. If they didn't have completes or immediate dentures, they got sent to the FD to make up a pair pretty sharpish. So I got loads of experience there. And we had an in-house lab there as well. So I was always popping in with a technician, and we had a CDT there. So yeah, it was just sort of really thrown into it. And I just like the amount of change you can get, especially like completes. I think I said it on a post the other day. It's a blank canvas. You've got a lot of control of what you can do. And yeah, I just find it enjoyable. I do all general dentistry, but my practice on Instagram is limited to removables at least.
Man, your passion just shines through. And I love hearing people's origin story, because a lot of dentists ask, how do I know what my niche is? How do I know what kind of dentistry I want to sort of niche down into? And I love your story that, hey, you had an influential tutor in dental school, and then you happened to fall into a practice whereby they had this contract with sedation, and you were seeing tons and tons of removable pros, which obviously just fueled your passion more and more. And now you're in a situation where you're really taking wonderful photographs and these brilliant cases. And listen, today is all about suction lower dentures, right? Because lower dentures are the bane of all dentists. And it all came about because recently on my Instagram, I posted one of my few cases I have where I managed to achieve suction on a lower full or lower complete denture. And in the comments, someone suggested, bring Rupert on. I think that's how it went. I was like, yes, totally. This sounds amazing. So I'm happy I have you on. I had Mark Bishop on. We talked about all things complete dentures. Yeah. Then I had Finn about chrome dentures. So I'm being a little bit harsh to you. I'm giving you the most difficult thing to discuss in removable pros, but mate, let's go with it. So the first question I have is, how do you know which case you have a chance, right? When do you know, okay, you know what, I've got a chance? Or do you always have a chance? Or are there some situations where maybe you want to throw in the outward classification or something that you think, you know what, it is impossible to get a suction lower denture? Give us a flavor of that.
Yeah, I wouldn't want to ruin the episode straight at the start and everyone logs off, but I don't think you can know, as you say, like outright, this one's going to be great, this one isn't. Because I've seen like the full range. You know, I've got a couple of videos on my page, which probably ones that you've seen or people have asked to see. And the one chap, he's got the most beautiful ridges, big, wide, awesome ridges, great upper and lower suction. And then I've got a lady who's got these non-existent inverted, and it's got suction as well. And so you've got the two extremes, and you get it. But I don't think you can ever know for certain. But as you say, I think you can achieve it with any ridge. You just got to sort of back yourself and go through with it.
So what Rupert, what percentages do you think is luck, and what percentage do you think is, because I put it down to luck. When I get it down, I was like, okay, I just got lucky, right? But what how much is skill? How much is, on a different patient that might not work, but on this patient it did? Is that a fair question? I don't know. You tell me.
Well, I think it's 50-50. You either get it or you don't, isn't it? So no, I think you've got to do everything the same all the way, like each time you do it, and then it's going to even itself out over the course of it. But I've had patients where they've come in and thought, oh, this is going to be an awesome, good chance of suction here. And I've texted my technician with the primary imps and say, oh, this is going to be a good one. And we haven't quite been able to get it. But I think actually, though, it comes down to, is suction actually important? Like, what is going to make it a successful treatment for the patient? I've never had a patient come and say, yeah, I really want a suction lower denture, please. They've gone, my lower denture is not that great. I want to make a new one. So it's great to have, but I don't think it's not the be all and end all. I think a supportive denture is probably better, because then you're more likely to get that stability, which is what they really need.
Brilliant. And by supported, you mean like some implants? So implant supported dentures, you mean?
It's just supportive in terms of, if you go right back to my third year tutor and you're saying you have the stability triangle. So your stability is your balance of your support and your retention, resistance away from the tissues, support, resistance towards the tissues. So particularly for the lower, gravity is helping you. I think issues that patients have is when they're biting and there isn't that much support and it rocks, it displaces, you've lost the stability. And no matter how much suction or retention you have, if you've got rubbish support, you're going to lose your retention anyway, because it's not going to be able to overpower that seesawing or whatever it is. So I think actually, I don't focus on getting retention. I focus on getting support, because I think I know 9 times out of 10, if I make a really nice supportive denture, it's going to be better than what they walked in with to see me at the consultation.
Make that really tangible, Rupert. Like, what do you mean? How can I make because I test for retention, I test for stability, but the support concept to me is, yes, we read about it and stuff, but it's not something I looked at denture and thought, okay, how well is it supported? What do you mean by support? Do you mean how well the lips and soft tissues rest over it, or how well it just sits? Give me a little bit more about the support and how we can improve the support of our dentures.
Sure. So I think your support in terms of finger rest either side on the 5s and 6s regions, pressing down, is it resisting against it? Is it feel like it's rocking? So you see those little mini complete dentures where the flange is essentially like the width of the teeth, when they've got buccal shelves, they've got a lingual extension, because we all have that. Even when there's that full resorption, you might lose the height, but you're still going to have the width of the mandible bone. That's not going to go anywhere. It's going to shrink downwards, but not necessarily inwards. So, I always look at seeing how far I can get it out towards the cheeks. Yeah, that's then going to play into your support of the cheeks and the lips, because we're not just replacing the teeth, we're replacing the bone, the hard tissue that's been lost as well. So if you've got those kind of nice extended flanges posteriorly, you're going to have a much better support, and it's not going to move around. And that's going to improve that stability, which is actually what the patient means when I don't have a tight fitting denture, or at least that's what I think.
Brilliant. That really helps. There have been some times in the past, especially as a DCT, I made loads of complete dentures back then. And sometimes I had overextended, I don't know if that's the right word. So basically in the lower molar region of my complete denture, I had gone too far buccal or too far towards the cheek. So how can I minimize that problem? And how do you know where your special tray should end in a buccal direction, in terms of how far does the periphery go in terms of the buccally, if that makes sense, towards the cheek? Are there any landmarks that you use to draw that out?
It's difficult to say landmarks. I think your frenal attachments are going to help you, because obviously there's not going to be a massive extension beyond a frenal attachment. So you can be a little bit realistic there. I think I always deliberately try and overextend the primary impression. One, to make sure I get all the landmarks that are going to help me. So if you want to get support or even retention, if you're looking at retention, you want compressible tissues posteriorly, your retromolar pads, you want to get the buccal shelves, you want to get a lingual extension. So you want to make sure you get all that in your primary impression anyway. So I do try and overextend it. And then I look at trying in my tray, making sure actually there is a free bit of sulcus around it that we can work into. So when we do a functional border molding impression, we're going to have the suitable thickness of material there, and we're not overextending it. So if you try your tray in and it's absolutely, cutting into the cheeks, and you get the patient to wrap the lips around and it's knocking you can feel it moving around, you've overextended then.
Awesome. That helps. So I think next, let's find out step by step. Okay. Just talk us through, obviously, you can go on 3-4 days teaching about this, because it's not something you can learn in a podcast episode. Let's just give people a flavor. Just give us some step by step, some things that you think have been instrumental in helping you to get better supported, better retentive, better stability from your dentures, lower dentures.
Just stick to the lowest. So I think first off, like assess the patient fully. I think Mark covered it really well in his episode. It's like, it's not just a treatment plan of like lower complete denture. Have a good look at the patient. Have a look at what do your ridges look like? Is it really flat? Is it nice and wide and thick? Is there a bony undercut? Does the patient have a large tongue? Have they not had a lower denture and the tongues and the floor of the mouth is expanded in and things like that? Look at those landmarks that you're going to get. I always look at what the patient has already, what their denture's like. If they've got one of those little tiny dentures, I think happy days. I'm probably going to be able to improve this. If they've got one with really nice looking flanges, I start to get a little bit worried. And assess other things. What's their saliva like? Because if they've got bone dry mouth, you're not going to get anything there. You need that thin film of saliva. And I think you need to assess how good the patient is at wearing dentures as well. I had a lady recently, just when we came back from lockdown, and she came in and she was a full denture wearer, and she'd been wearing for 40 years, and she just went, I just want something that looks nicer. And I thought, happy days, because Ricardo will sort that for me. And she had no bone at all, and her lower denture, when I was assessing it, was absolutely swimming around all over the place. And I was like, how are you with that? And she's like, absolutely fine. She's one of those, I like to use the analogy of like riding a bike. When you're riding a bike, you're super stable, but one leg's going up, one leg's going down, but you're super balanced and you're fine with it. And she was riding the bike. This denture was moving everywhere, but she was absolutely fine. So if you've got a patient like that, happy days, you might improve it, but it's not going to be the end of the world to them.
I mean, that patient has a superior neuromuscular adaptation, right? That patient is a good denture wearer, just like you said, so these patients are kind of sometimes, don't never get complacent, but they're kind of home runs where they've got this crappy denture and they're wearing it. And, those are ones that I like to take on. And when it's not that criteria, I like to refer them probably to you.
Yeah. I'm only down the road, so you know where to find me if you want to.
Oh, absolutely. Absolutely.
Yes. I think those, no, I think those ones are, as you say, they can be the home run. I think the toughest ones are patients that are transitioning, like perio patients transitioning maybe from a partial to a complete, or like I had a chat, the ones that I've been sharing recently, the fancy signature ones where he'd actually never been wearing a denture. He had a really bad gag reflex. He'd never worn dentures, but he's been a dentureless for 10 years. And that's like you're saying, you've got to learn this. Like it's a skill. And I use that riding a bike analogy, and I think they sort of get that. Those are the tough cases. Yeah. And especially in immediate when they're numb everywhere and their lips are pushing it all out already because they can't move them. I think those are the challenges. But yeah, the ones where they've happily worn them for 45 years and they're expert denture wearers, happy days.
Sweet. So you talked about the patient profile, like what you just said there. You talked about your primary impressions where you're trying to get them overextended on purpose. Let's move on to maybe some pearls in the special tray, because that's really such a key appointment, to get your final impression. You mentioned green stick and I don't think you mentioned border molding, but my question now is, can you describe your technique for border molding? Do you use green stick?
Yeah. So one little thing that I didn't mention earlier on the primaries as well, I think just use putty. Don't just stick alginate in there, because you're not going to get that retraction of the tissues. You mentioned green stick and stuff there as well for your secondaries. You want to make sure you're retracting those tissues, because you're not going to get the buccal shelves. You're not going to get back to the retromolar pad, and you're going to end up with that tooth wide denture again. But yeah, secondaries, I don't use green stick. I just don't like using it. It's just really fiddly. I prefer using putty. But I actually do my secondaries in a 3-stage impression. So I do, the first stage might be a little bit different to what sort of people do. So I've deliberately overextended, not massively, but overextended. So I know where the frenal attachments are, so Ricardo can cut them back. And then what I'm doing is I'm placing that tray in and checking it, seeing that I can see that I've got my 3 millimeters of free sulcus. And then what I do is I take a little bit of putty, and for a lower, I'm going to do 3 balls of putty in the tray. So I'll do one each side in that sort of buccal shelf, retromolar pad area, and I'll do one in the incisal. Place the tray in, get just patient relaxed, place the tray in, check that I can see all the way around my 3 millimeters of buccal sulcus, and just leave it there for it to set. Once that's sort of half set or mostly set, you can take that out because it's just as a guide. But what it means then is every time I place it back in, I know I can push down and I'm not going to push it too far in and overextend it. And also it means that every time I put it in for the other 2 impressions, it's locating in the same spot. every time.
That is awesome, man. That is a fantastic pearl. I've never thought to do that before, so I've definitely learned something there. I'm going to write that down. That is a beauty right there. So what next? So you got your putty balls. You got like a triangle, something that's quite stable, like you said, and you can visualize at 3 millimeters, which is genius. What next?
So next I'll do my border molding. I'll do the main body of it again in putty. So you could do green stick. If you want to do green stick, like happy days, go for it. I just prefer the sort of the feel and use of putty. So I'll do putty around the edges, get my good border molding. So then I know that when I place this in and the putty's got that thickness of 3 millimeters, place it in, get a functional impression going. And I personally do it completely patient driven. I don't like doing lip pulling or anything like that. I think that distorts your sulcus shape. If you pull a lip, you're going to have the muscle being long and thin, whereas a muscle in function actually is shortening and fattening. So it's probably only a marginal gains thing, but your sulcus shape is going to be slightly different. So I'll place that in. My rest seats, my soft tissue stops is stopping it from overextending. They're then wrapping the lips around, the oohs, the e's, opening wide, obviously for a lower, moving the tongue around left and right, forwards and backwards. And then they are compressing and pushing that back up. So then hopefully we've got exactly the functional depth of the sulcus rather than just the static depth of the sulcus. And I think it's really important if you're doing that kind of patient-driven border molding that you're really, I really get into it. Me and my nurse end up probably doing it under our masks as well. But you sort of really hype them up and explain how important it is. And you say, well, if you don't do this properly for me, every time you try and say, oh, look at that, your denture is going to pop out because your lips are pushing it up. So, and really getting to exaggerate it, and you can have a bit of fun with it, really. And patients quite end up laughing half the time, which is quite good because most people hate impressions and things. That
is great. And I think it's so important to know these things that you say. So oohs, the e's, to get that sort of functional movement of the muscles. My favorite thing learning as a DCT from Professor Mike Fenlon. Are you familiar with Professor Fenlon? Mm-hmm. So he with his fantastic Irish accent, I don't know if I've said this on an episode before, but he'd say to patients, smile like a politician, pout like a supermodel, and all these things. It's just, patients love that, and it's a great thing to make them laugh and stuff. So I think you definitely got the right idea there. Brilliant. So you've done that with more putty. Now, you were mentioning about green stick. You don't like using it. Have you used pink stick before?
I haven't. Talk to me about pink stick.
Oh, pink stick is like green stick's like sexier cousin. Like it's so good. Like I used it. I used it at Guy's Hospital once because my consultant then Sarah Tubbiett-Paul, her little hack was green stick is rubbish. Don't use it. Use pink stick. It was so much better to handle. And I don't know where to order it from. I never order it again. I don't do enough dentures. But check out pink stick. Let me know what you think, man. It'd be cool to see what you think of pink stick. But pink stick was really cool.
Pink stick in.
Yeah, please do. Let me know what you think, man. But cool. So you're using putty in that way. You've now done your initial 3 balls. You've done your functional movements, the oohs and e's. You've made the patient laugh. You've made something out of it. What's the secret sauce?
And then the third stage, either I'll use a light body, a medium body. You can use an alginate again if you like. It's just getting that fine detail. But I prefer using a silicone. So because what I think is if you're using the silicone, place that over wash impression style, and then exactly the same border molding again. Hopefully you'll get nice little sort of strips of light body around the frenal attachments. You'll see it just about wrapping around. But again, so I place it in mainly for a lower. It's going to be get the tongue up first so that you're not trapping that and you're sitting it down nicely. And I think if you have the tongue up and out of the way first, you're not going to, if you're dragging that impression down against the tongue, you might be pressing material away and you won't get the full depth lingually that you might be able to. So I get them to roll the tongue right back, push it forwards, left and right as far as they can. Get them to press into the tray as well, activate the anterior sort of floor of the mouth. And then, squeezing the lips, doing your pout, as you say, saying oohs, cheesy grins and e's, opening wide, wiggling the jaw left and right. That's more for the upper, really, get the coronoid processes and things like that. But then light bodies like that. And the reason I like the silicone is actually I can take it out, put it back in, and I can assess almost straight away how reliable that suction is. Because I think you can do an impression if you put a load of alginate in there and there's loads of saliva trapped and it comes out and it makes that lovely suction sound. You think happy days, but actually it might have been that it was just stuck in an undercut or whatever it is. But if you can repeatedly put that tray in 2 or 3 times and you know that that's a reliable, repeatable suction.
Any concerns about any bony undercuts? Is there anything we should be doing with the significant bony undercuts?
Yeah, I think undercuts, I've not actually made a complete yet with sort of big mandibular tori or anything like that. I think you obviously want to avoid them because they're going to be sore, particularly tori. The gingiva is so thin there anyway. So again, that's sort of try and capture them in that primary impression. Make sure your technician's aware that you want to avoid those and get the tray. So you've almost got to sort of deliberately get it a bit wrong in the primary to be able to get it right in the secondary. But you want to be avoiding that really, because it's going to just cause you a nightmare in terms of where you're going to end up with extending it, and you're going to end up cutting it back loads when it's rubbing and it's sore like that. But yeah, I've not actually had. It's probably like the one sort of thing that I haven't had yet for a lower that I need to get. So if you see one, send it to me. Yeah,
you're gonna hate me, man. But no, this is cool. This is cool. I like where this is going. So you really described quite beautifully the impression stage. I think loads of people are driving right now, chopping onions, running, and their next lower denture, they're gonna be like impression stage. Like, yes, I'm gonna do exactly how Rupert described it, because I think you described it really clearly. What are the other, you don't have to go exhaustively into the other appointments, but just a few pertinent points in terms of what you think is important to getting a good lower complete denture.
Yeah, so obviously, like you've done some good imps, you're going to do your reg appointment. Gold standard, you want to do it on an acrylic base, really. One, if you're doing that off your secondary impression, then you're going to know pretty well how good your secondary impression is. And if you want to, you can always then reline that if you're concerned, light body, Zoe, whatever you want to do. But also obviously having it acrylic base, it's going to make it more stable. You're going to get a more accurate registration. I think the best thing, if you want to talk about the reg and stuff, is go and listen to the other Complete Denture episode from Mark, because I think he nailed that really well. Look at previous photos. I'm not sure if Finley mentioned it in his episode because it wasn't really on acrylic, but he's a big advocate obviously of photos from before. You know, the classic class 2 patient, skeletal class 2, you make them class 1 for a complete, and their lower denture keeps pinging out because their lip, is pushing it backwards because you've massively invaded the neutral zone. Check those kind of things if you can. That's where like the photos are really, really good. If you see someone who's a barn door skeletal class 2, make sure that you've adjusted your rims suitably and appropriately. Wax try-in, there's not really, I wouldn't say there's much special stuff there. I think what I try and avoid, if the patient thinks it's overextended in wax, I would say just bear with me and let me process it, because I'd rather polish off an acrylic than accidentally lump off a massive bit of wax. I don't know if you sort of agree with that, but I think sort of I'd rather have the control of a straight burr rather than sitting there with a wax knife and accidentally take off half the flange that I've worked so hard raising the tongue and booing and ahhing for.
100%, man. You don't want to see my wax work. I think those are my stressful moments as a DCT were always with a wax knife in hand, a Bunsen burner, and just a mess of wax, and my nurse just looking at me like, what the hell is he doing? Yeah. So definitely, I share that sentiment. I think it's good to tell the patient in that way. So really the wax try-in for you is more aesthetics and phonetics?
Yeah, 100%. I think, especially with sort of more of the cases that I'm doing and sharing now, there's quite a high aesthetic component in them, or at least for me and my technician, we're pushing the aesthetic side, and patients don't always appreciate their lovely Fenaris 2 teeth and things, but we do. And but yeah, we've had a few cases recently with old photos and things like that, which are really fun to do. So it's more checking that, and yeah, again, you can get an acrylic base inside your wax try-in if you want to again assess that stability, support, retention, whichever you want to sort of worry about. So yeah, the wax try-in generally is my favorite appointment. You're really anxious about it first because you think it could all go terribly wrong, but generally it's like the easiest appointment. But yeah, and if you're a little bit worried, again, just like if you're feeling like your wax try-in, particularly if you haven't got an acrylic base, if you're thinking it's not feeling that stable, I'll always just put in a bit of light body, seat it in, reborder mold, and at least then it's going to be, even if it's just the fact that it's in wax and it's not retentive because it's wax rather than acrylic, that's just going to make it stable, gives the patient confidence. If you send it back and your technician looks at it and goes, no, it's fine, it fits fine, it's not a problem, they can just peel it off. If they think, oh, actually, that might be quite good, I'll recast that and use it almost like a reline impression, then you've not lost anything. So I think that's a little thing that I'll sometimes do at the wax try.
That's not a little thing. That's a massive thing. That is a huge gem. So usually I just maybe put some fixative in or something, but the light body is just a genius idea, because not only are you improving the situation then and there, but then your technician might find that information useful. So that is a huge pearl. Really appreciate that. So used light body. That is wicked. Dude, I was just thinking of a story. I remembered a patient I saw at Guy's Hospital, and he's not a great denture wearer. He's about 85 and he's on his 5th complete denture in the last 6 years. So you know where this is going. The ridges looked okay, and it fell upon me as a DCT to inherit this case. So I started making these complete dentures, and I got to the wax trying stage. On that day, my consultant just wasn't around, so I was by myself, right? And the patient goes to me, I wish there was a way that I can test if this is going to be good. I want to eat something. And I thought to myself, is this kosher? I mean, can the patient try and eat something now? And lo and behold, his carer and him, they had a peanut butter sandwich. So on his wax trying, upper lower wax trying complete dentures, he started to eat this peanut butter sandwich. Do you know if this is a good way of assessing anything, or that's an absolute waste of time? Because I felt it was a massive waste of time, and it probably just went back with like peanut butter residue back to the lab. But at the time I was like, let's give it a go. Why not?
Yeah, I think... I mean, Ricardo gets a bit touchy if I let the patient bite down a little bit too hard and the teeth have moved a fraction. So I think he'd kill me if I did that. I think the problem is with wax, unless you've got it like a processed acrylic base, the fit's never going to be as good. And I always say that before I've even taken out the box for the wax try, I've said, look, this is wax. It's not going to be great. It's going to fit way, way tighter when it's plastic. The saliva doesn't work the same. And so I think if they're worried, and it could be a stability thing, I'd do a little cotton roll, pop it in one side, give it a little bit of a bite, because then they're not going to be really crunching through. It's more just testing that sort of support and stability. But yeah, no, I think if I sent Ricardo a peanut butter covered complete, he'd probably not work with me ever again. I'd need a new technician.
Brilliant. Just something that I remember it had flashbacks, but yeah, nothing I'd advise for sure. And I thought you'd agree with me in that sense as well. It was a stupid thing to do, but hey ho, it's something I did back when, and becomes a story. At the wax trying stage, what if are you really thoroughly checking the occlusion? Because are you checking for any interferences to centric relation? Because at that stage in the past, I have sort of just heated up my wax knife, made some of the teeth or the wax underneath the teeth a bit loose, and get them to bite again to sort of intrude that tooth. Is that something you're doing, or do you tend not to also mess with the occlusion until you get to, unless it's way off? Or how do you manage that?
Yeah, I think the main thing I try and do with wax try-ins is I pop them in and just try and instantly start talking to the patient about something else, and just let them sit with them in for 4, 5, 6 minutes. Annoyingly, I've got a really big mirror in my main surgery that I work in, and I try and deliberately stand in front of it so they can't spend any time looking at it yet, and just literally let this sit there and let them wear them for 3 or 4 minutes and see what they think. Obviously, if they're falling straight out and you need to do that little light body reline, then do that. But I try and not ask too many questions or think about it too much. I've got the luxury that obviously I'm doing it all privately, so I've got loads and loads of time for my wax trying and things, so I'm not squeezing in a 15-minute wax try. But I think just let it sit and settle there for a little while, and then just ask them, how does it feel? Is it comfortable? Have you got the OVD right? And I think have a good look at it. And yeah, if there's an obvious point, then absolutely I'd do exactly the same as you. Heat the wax knife up, sort of get it underneath, allow them to then intrude themselves into a position that feels more comfortable. I think the main thing though is photos and full face photos for wax trying. Even things just like a slight midline shift. Like we had a case that we did, and I know did like a nose to chin one, and Ricardo was fuming because he wanted some eyes in there to be able to, because we felt the midline was slightly off, and he managed to fix it because he's that good. But take photos of your wax try, take photos of your wax rim with your midline, because again I had there's a window impression. I actually did a post about it. Actually, there's a window impression case that I did, and I'd drawn the line, and you're not going to like mount the patient and sit exactly in the middle of them. I do it from the left or the patient's right, and I lean around, and I'd done the midline at a slight angle, probably 5 degrees or something. When I looked at the photo, I went, oh, that's obviously wrong. and sent it to Ricardo. We have everything in a Dropbox and things like that. And he's got a full face photo, and you can see that the top of the line is exactly right where the nose is, and then it cants off to the side like that. And he was able to just to adjust it, and then it's absolutely fine. So I think that's the thing as well. That take photos of everything, wax rim, take photos of that in the mouth, and you can check your smile line, you can check your interpupillary, you can check your alatragal if you want to, and confirm it with photos. I think even if I'm doing a presentation middle of February for some undergraduates, and I realized I didn't have at the time anyway, any bite plane pictures of a patient. So I just took some on a nurse, and she was a little bit sort of class 3. And at the time I took this side on for alatragal, and it looked great. And then I put it in Keynote to do the slides, and I drew the line alatragal, duplicated the line for the angle, and dragged it down, and she was off by 10 degrees. And I was like, oh, I probably would have thought that looked fine actually. And have I done that with some cases? So that was a big thing for me, is that I'm going to start taking these side-on photos and confirming these things on Keynote with either with Ricardo later, or I might even start doing it in surgery. But yeah, I think lots of photos, because you can rescue a lot of things, but I try not to change too much of wax try. Going back to the original question.
No, that's great. And two main takeaways there is take the full face photos because they're so valuable, and also find your Ricardo. Everyone should have a Ricardo. This Ricardo guy, he sounds great, man. He sounds like he in a banter way, but he pushes you, and he gets you to do things in a certain way. I think you guys feed off each other, and you guys are both very passionate. So find your Ricardo, and at the end you can tell us how you can find someone like that. But yeah, we're both as sad as each other, really. I think that's the thing, and he makes me look good. So definitely find yourself a Ricardo, but not mine, because he'll get too busy. Shout out to Ricardo, but please don't use Ricardo, or we might not see as many Instagram.
Shout out to VR Dent Studio.
do the shout out properly. What's the name?
I tag him in everything. So VR Dent Studio. I tag him in every single post. So yeah.
Oh well, that's very good of you, because there's some dentists there who post these beautiful veneers and stuff, and they don't credit the technician, where they've taken a monoblock patient to these beautiful translucencies, but it's actually the ceramist who's done a lot of the work, or the complete denture cases. So it's very good of you to shout out to your technician in every case that you do. That's amazing. No,
100%. I mean, we've built up a really good relationship, and our cases wouldn't be as good if it wasn't with his work. As you say, we sort of push each other, we understand each other, and it's just about building that relationship. And I think that's the kind of thing with these kind of cases, is about consistency. It's like consistency with how you take your impressions, consistency how you assess the case, what you ask for with your lab work, and like with your technician. And it's difficult when maybe you're in NHS or in mixed practice, and you send it to that lab, and it's a corporate lab with 20 technicians in it, and you don't know who's getting it, and you get one thing back from one person and one thing back from another, and they never read the docket. That person, it's come back from them because they've done the wrong thing. Or so I think even if you're doing it, sending it to a lab like that, try and get to know someone there, and because there will be one technician there that wants it, and it might be that all the great technicians will probably work in a place like that at some point. So chances are there's probably a great technician in the making there, and find them and go along for the ride with them, rather than I've just sort of piggybacked on Ricardo when he's already been smashing it. There's always a chance you might find that person and work together and grow together. I think Finley covered that, didn't he, with sort of what he was doing.
That's it. He said find someone roughly the same age as you and grow together. And I think you've given a good tip there, that even if you're sending it to a corporate lab, like visit that lab if you can, and find that one guy who might be that dark horse that you've never met before. You've seen their name on the sheet before. Now you get to say hello to them and say, would you like to buddy up with me? We can do cases together. And only if you see that fire in their belly and a twinkle in their eye, that you can start saying, you send it to corporate lab 123, but FAO, whatever their name is, and then you sort of, all that case will always go to them and build that relationship, which is awesome. So I'm glad we covered that as well. So now on to the fit appointment, my friend. On to the fit appointment. Talk us through your workflow. Like I know some dentists will try it in and see how it goes. Some dentists will straight away put on what's that green stuff by Coltine, the pressure spot indicator, that straight away before they actually get the patient to try it in. What's your protocol, man?
Yeah, I just, similar to the wax try and rate, just pop them in and again, try and instantly start talking about something else, or not even thinking about it. Like, make it a really matter-of-fact thing. We're going to pop these dentures in, happy days, see how they feel. I mean, I try and even not adjust them at all on the day if I can, unless there's an obvious sore spot, it's definitely digging in somewhere, or there is there's an undercut that we've slightly gone into or something like that. Then obviously I'll adjust that. But I think with these cases, and we said, we keep saying about the little tiny denture with the non-existent flange. Realistically, I'm probably making something a lot bigger, and I've already said that to them. Appointment one, I think it's really, really important in that assessment appointment that you manage those expectations straight up. It's going to be bigger. It's going to take you some time to get used to. You've got to retrain the muscles. It's going to rub. I use this like fit appointments, all about like a shoe analogy. Even if I'm doing these super fancy signature characterized dentures, you say, well, no matter how expensive a pair of shoes I've bought, they've always given me a blister. It's going to take time to break in my £300 pair of Churches or my £10 Primark pumps. They're going to rub either way. So give them a little bit of a chance. And it's a new set of trainers. You're not going to run a marathon on day one. You're going to go for a walk around the block first, or wear them around the house. You're not going to head out and do 42k straight off the bat. You've got to give them a little bit of time. And for those ones where they've had a teeny tiny denture before, I sort of say, well, let me make it gold standard, or let me make it as textbook as I can. Give it a week, give it 2 weeks. And if we have to compromise, that's absolutely fine. And we can adjust it then. But then it's a bit like the wax drying thing. I can trim it off. It's a whole lot harder to make a flange longer after I've made it. I'd rather cut it back than, try and add it on again. That's because that's just not going to happen. So, I just try and get it in as best I can. And if there's an obvious sore spot, something needs polishing, then fine. But I try not to touch it too much, because you can sort of say, well, we've made it as potentially as good as it's going to be, textbook or whatever that is. And it's all about feeding that in throughout the entire process. And that's where, again, having a technician that they have accountability. Ricardo's mentioned in my first appointment, I mentioned by name, because we're going to do photos of everything. I do pre-op, full face photos at the first appointment. And you build in how much work you're doing. And I think the way that I do them, probably like your chap with 5 dentures, I doubt the other 5 dentures were made in the same way. So they sort of go, oh, there is a process here. Like, I can get behind that. Let's do what he says. Let's give it a week, 2-week review. And, they believe in it more. I think the psychology is really, really important in denture wearers.
What percentage of your patients, when they come back to see you a week or 2 weeks afterwards, will have an ulcer at the flange area?
Probably about 20-30%.
Bloody hell!
Usually lingually, because I tend to really, really go for it lingually, because that's a gimme. There's loads and loads of sulcus depth there, and mostly they've never ever had a denture there before. So you say, look, it's. You say the shoes again. You say it's not only your new set of shoes, but you've never had a shoe that long before. It's going to rub. It's going to rub in a different place. I'd say probably about 30% maybe.
That's remarkable. How many dentures? Have you ever done a denture? And maybe I'm sounding stupid here, but where you have given the final dentures, they've gone away and they come back, everything's fine, and you don't need to adjust anything. For me, I just can't imagine that ever happening. But maybe you're going to prove me wrong.
I've had 2 in the last 3 months that I haven't seen for a review because they just cancelled it and never came back. I'm hoping that's happy. A good thing, because they're happy. We've been in touch. One guy was work related, COVID at work and things like that. So he's been in touch. He's like, no, I'm fine. I don't need to come back. So a lot of the time we'll come back for a chat anyway, and I'll say that I want to see them or do some more photos maybe, particularly if it's like an immediate.
The review, aka the photo shoot.
Yeah, that more or less that's what the review is most of the time. Yeah, but no, I'd say quite often actually, and it might just be that it's a slight polish, or they found it one specific movement. Maybe there's a slight interference somewhere, and it's just a little occlusal adjustment or something. But I'd say generally, probably about 30% need something doing, but most of the time they're quite happy.
That sounds crazy. That's like witchcraft to me. So wow, that's very impressive. That is wow, just remarkable. Tell us about when you have been able to achieve a suction lower denture. Is it obvious at that fit appointment, or have they sometimes gone away with you haven't got that suction, but when they come back for a review, they now have that suction after a review? How does it happen usually?
I mean, I think the two videos that I've got on, they are day of fit videos. I literally just pop in, hear the squelch, say sit there for 2 minutes, give them a little squeeze together for me. And I think that's really important. Like, don't just pop it in and expect it to be suction straight away. You've got to let it bed a little bit. So yeah, both of those, they were straight in. But yeah, I've had a couple where one of the chaps, the guy who had the COVID case at his work and didn't come back, he called and said, "Oh, the bottom one feels so much better now. It's fitting really nicely." And this is the chap who'd never worn any dentures at all before. And he had a massive tongue, to be fair, which probably helps sort of support it and balance it. So yeah, I think you can definitely learn to adapt the muscles, because it's more, again, about that stability and not displacing it. Learning to ride that bike, not displacing it and knocking it out, which is going to interfere with having a continuous maintained suction. But generally, if you pop it down and you hear a squelch, then happy days, you're probably going to be all right.
Now, for us normal dentists, not at your level, Rupert, with Complete Dentures, one tip I want to give to the more average the dentists at Removable Pros is that one of the pieces of advice that was given to me by Lyndon Cabot, I think he's a professor or doctor. Dr. Lyndon Cabot, he told me that sometimes as dentists, when we give complete dentures, just have patience. We're so tempted to do something, pick up the handpiece, do some adjustments, whatever. Just let them go home with it. It's like you do. And then sometimes they just need more time until the situation improves and improves and improves, and you haven't done a thing, and then suddenly they're able to keep it in. So sometimes they just need some more time. Is that a fair thing to say?
Absolutely. We said it before, that muscular control, that's really, really important, especially for a lower. The upper, you can get that suction cup effect, and you'll be fine. For the lower, you need some element of skill to maintain it. And you even say to them that you've got this. You heard the squelch, right? And they go, yeah. And you say, well, it's going to be lost because your tongue's flapping around all over the place, and you are constantly pressing it and moving it. You've got to learn that you'll sort of subconsciously realize that seal is wearing off, and I just need to bite it down, or I need to rest my tongue over the top of it. And actually it's that, rather than them thinking that you're going to pop it down, it's going to sit there quite happily forever and not move. You say, no, you've got to keep updating that seal, that suction. You've got to keep pressing it back down with your teeth, but you'll get used to that. You won't have to think about that in a week, 2 weeks. And that's where you get the improvement over time, is that they're learning subconsciously. They're not thinking about the fact that it's losing the seal and it's getting loose. They're just biting it down and that's it. But no, that's definitely right. That's why I say just try and send them off, and unless there's a glaringly obvious bit that's occlusally wrong, or definitely you've got a flange wrong and you haven't got the extension right, adjust that. But if it feels pretty comfortable and they're good to go, I'll just try and send them out the door as well as you can.
Amazing. Well, before we, I want to ask about some of the educational stuff that you're putting on, but before we get to that, just last question, because we can't do an episode on Protrusive without talking about the occlusion. Just tell us about the fit appointment and maybe the review. What's the most common thing that you might do for the occlusion? I mean, do you actively look for this bull rule, buckle of the upper, lingual of the lower? Do you try and do that? Give us a bit of a minute or so on the recipe for success with occlusion with dentures.
Obviously, you're taking that from your reg appointment. Make sure you're getting your simple things right. Your alar tragal plane, you've got it, getting a nice lower lip line and things like that, so that everything is where it should be, and you're not making the patient work harder than they should in terms of the fact that the angle's off and they're getting contact too early, or you've got this odd shaped lower that's having to work with the sort of wrong occlusal plane of your upper. I think really it's about making sure they're comfortable and get them in a retruded position that feels comfortable for them. Make sure that they're happy with it, and then make sure they're not a blatant class 2 or class 3 that you've missed, and just set them up. And I think as well, maybe it's a NHSE mindset of 4 appointments, get it done, but I don't mind doing 3 wax try-ins, 4 wax try-ins to make sure I've got it 100%. And you say that to the patient, you say, we're going to do the first try-in. And even the fit appointment, half the time I might say, we're going to try it in the plastic, and we might still want to make some changes. And, a bit like you could sort of say it for crowns as well. We'll try it in, and we might need to, alter this or that and send it back, and like you would with maybe an implant crown. But I think, don't be afraid to do another try-in, and you make sure the patient's 100% happy as well. But I think you can sort of tell quite quickly, occlusion-wise, the worst is when you pop it in and you've suddenly got like a 2-unit midline shift and they've got a complete scissor bite on one side or something. You think, what have I done here? But it's just because suddenly they feel like they've got a denture in rather than a wax block, is that they suddenly bite in a completely different place. And I've had that a couple of times, not quite that drastically, but where it is just a little bit off. And I think, see if you're happy with the upper, make sure the upper's set right. I think Mark said it in his, the upper is for beauty, the lower is for the function. And, I do a lot of taking the posteriors off the lower. If I'm happy with the upper, take the posteriors off, 4, 5, 6. Don't put 7s on. Don't put 7s on completes because they're just going to give you more problems. Take the 4, 5, 6 off. Leave the incisors if you can, and potentially just re-reg them at that point because they've got an incisal. Hopefully, the incisors then might go into the correct place. You can reg them then and just get your technician to reset it up there. If you're completely off, dig out your wax rim, your lower wax rim. Hopefully, they haven't destroyed it. But yeah, I think don't be afraid of doing multiple wax try-ins and build it into cost of private treatment, or and just again be upfront about. I think the whole thing, be super upfront early on, because if you start saying things are difficult at the wax try-in, it's an excuse. If you told them 3 appointments ago, they go, oh yeah, you did say that we might have to try it in a few times. It's all about just not being negative or pessimistic, but just being reasonable and managing those expectations.
Brilliant. Because the communication is half the battle now. Rupert, as you know, with Protrusive, I'm a massive promoter of education, and with people like you who just do so much for our dental Instagram community, and you post these beautiful cases, and I'm sure you get DM'd all the time like, hey, you know what, can you help me with this case? Or how can I get photography like yours? Or how can I get dentures like yours? I saw that you promoted a course recently. Please tell us about that, because I know loads of the Protruserati would be interested in that. So give us a flavor, man.
Yeah, so we announced it, was a couple of weeks ago now. It's Ricardo and myself, and we've teamed up with Rodri Thomas. I'm sure everyone will know who Rodri is, because actually Rodri was a big inspiration for me and how I do the secondary impressions I do. So I was seeing some of the pictures that he was putting on. I know he's not that sort of known for it on Instagram, but he takes some incredible impressions and makes some amazing dentures. And I sort of looked at what he was doing and tried to reverse engineer it and experiment. And so I did his Art of Resin course, which is awesome. And we started talking about dentures there. And yeah, so we're looking at running a course. It's called the Art of Completes. And the plan is it's a 2-day course, take you through start to finish, with a live patient, with Ricardo doing the technical stuff in between as well. And we're just trying to cover that start to finish on how to get, hopefully, a reliable suction thing. So I'm hoping I didn't give too much away in the secondary impressions chat that we did. Otherwise, I might get it.
No, buddy, honestly, we really appreciate that. I think we really appreciate that. And I think anyone listening should really appreciate the level of detail that you're going through. You gave us so much there, but there are so many mini steps and gems that it's impossible to give out in a podcast episode, but you gave massive value there. So guys, if you like Rupert's content, support him in the course. I have no doubt in the world with Rodri and yourself involved and Ricardo that it's going to be a highly educational, really supportive course on something that just doesn't get taught well enough at dental school because of a lack of cases. We just don't get to do enough cases. And before we start getting fancy, it's about getting those foundations right, which you are so good at covering.
Yeah, no, I think I actually had someone write to me today saying that, they're a recent graduate and they're worried about X, Y, and Z and reorganizing the OVD and do it. And I was just like, wind it back a sec and just, I think pros actually is quite not easy, but it has a few basic concepts. If you master those and then sort of extrapolate them, you can work out more difficult cases. Think about balancing your support. Just think about those 3 basic things, and then you can do more challenging cases, like a big fibrous ridge upper, for instance. I know we're talking lowers, but a big fibrous ridge. That's just that you've got across your ridge, you've got an imbalance in the support, and if you just put one uniform piece of plastic there, it's going to rock and rotate. So how can you get around that? And I think that's what I like is it's problem solving, and it's just working through things like that. But I think work on the basics, and then that will open doors for yourself in doing more challenging things. And talk to your technician as well. If you've had any, like you said, still saying about the occlusion, things like that. I want to do my normal cop-out answer on Instagram, which is my technician actually sorts most of it, so ask him. And he'll be able to point you better, because I think that's part of it. Ask their opinion, and because it's a team thing at the end of the day.
Amazing. Rupert, thank you so much for bringing so much value on suction complete lower dentures. I hope everyone listening got a lot of value from that. I know I did. I picked up a few gems I wrote down. So excited on my next lower denture, which might be a year away. As you can see, I don't do that many. And then the next really crazy one I get is definitely coming your way. So thank you so much.
Cheers, man. Thanks for having me on.
Thank you, Protruserati, for listening all the way to the end. I hope that helped you to be more confident on lower complete dentures. Do check out Rupert's work on Instagram. It's absolutely amazing. His Instagram handle is Dentist Rupert. Do also follow at Protrusive Dental if you're not already. And just check out the quality of his photography, the quality of the treatments he does. He takes these fantastic portrait photos of before and after. And these dentures, I tell you, they make these patients look about 20 years younger. So Rupert, keep up the amazing work you're doing. And I hope you'll catch me in the next episode, which is 5 things your technician wished you knew.